Then we have a multiple myeloma. Yeah, multiple myeloma. Most of the time, this one will present as a disseminated disease. That means basically it will have spread or will be all over the body. Yeah, so the most frequent presentation is as a disseminated disease characterized by widespread bone marrow involvement. So it will involve, there will be widespread involvement of the bone marrow. And this one is characterized by neoplastic proliferation of terminally differentiated B cells. So those cells that are finally differentiated, and remember one of the functions of B cells or plasma cells that they have fully developed is production of immunoglobulins or antibodies. So characterized by neoplastic proliferation of terminally differentiated B cells that have developed the features of plasma cell and so can produce large amount of immunoglobulin. So immunoglobulins are the antibodies. And then we have Bence-Jones proteinuria. Basically, these we have what we call immunoglobulins. And in immunoglobulins that you have to look at in your immunology, probably you will, if you have to do immunology, you'll be told about immunoglobulins. We have IgG, IgA, and so on. And immunoglobulins have a heavy chain, and they have what we call light chains. So those immunoglobulins in multiple myeloma are abnormal. The production of immunoglobulin are abnormal, and they'll produce a lot of light chains. So those chains, and they are basically proteins. So immunoglobulins are proteins. So there is Bence-Jones. So this is somebody, probably was named after somebody called Bence-Jones, who first described these proteins that are found in multiple myeloma. So mainly they are the light chains of immunoglobulin, and they are abnormal. So you are able to find them in urine. When you talk of proteinuria, that means it is passed in urine. So if you have to examine the urine, you will be able to see these proteins. So there is Bence-Jones proteinuria. That's the light chain component of immunoglobulin. As we said, immunoglobulin has a light chain, and we have the heavy chain. So the most common types, so they are called also paraproteins. These Bence-Jones proteins are called paraproteins. And the most common one is IgG, immunoglobulin G. So the features of multiple myeloma, you'll have anemia, that is low hemoglobin level. We have thrombocytopenia, that is low platelets, and also generally immune dysfunction. So the immunity will be affected. And then another thing that we have in multiple myeloma is bone destruction. Yeah, and in bone destruction, somebody is likely to present with pain that is originating from the bone. Lytic lesions on the X-ray. Lytic lesion is basically lesions that are destroying bone. So if you do an X-ray, you will see places that are bone with a lot of bone destruction. So if you do an X-ray, you see areas of bone destruction. So basically, that's what we mean by lytic lesions on the X-ray. Yeah. And of course, because of those lytic lesions, this bone destroyed, there is increased risk of bone fracture. So one of the things that somebody may present with, somebody with multiple myeloma, they just present with bone pain, or they may present even with fractures, that when you do an X-ray, you realize there is lytic lesions. So basically, such fractures will be fractures that we called the last time. I think when we talk about fracture healing, we talked about pathological fracture. Basically, fracture in a bone that was already diseased, that was already affected by disease. And so the bone in the first place was weakened by the presence of a disease. So one of the diseases that can affect bone and causing it to have pathologic fracture would be multiple myeloma. And also it can affect the kidney. Yeah. So you can have renal disease and even hypercalcemia, because remember these there is the Bence-Jones proteins that are secreted through, so they can be filtered in the kidneys and actually can affect the kidney. It can even lead to renal failure. And of course, you can know hypercalcemia. Why? Because there is destruction of bone, there is lysis of bone, there is bone lysis. And you know, one of the functions of bone, which we talked about, I think in Anatomy 1, was storage of calcium. Yeah. Because basically bone is calcification. There is calcification for us to bone. So there is a lot of calcium within bone. So when you destroy bone, you release a lot of calcium into the blood. And so you have hypercalcemia. That is high level of calcium in blood. So if you have to take a blood test and examine, you see that the calcium levels will be very high. So you can have renal disease and hypercalcemia. So if you do a blood test, you realize the calcium levels are very high. So sometimes you can have a solitary mass lesion in bone. And this one you call it is termed plasma cytoma or cytomas if there are many solitary lesions within the bone. So malignant plasma cells produce cytokines which stimulate osteoclasts and result in net bone absorption. Remember, in bone we have osteoblasts, which basically help bone building. And when you talk of osteoclasts, yeah, we're talking of them being like macrophages in the bone. They are bone, they destroy bone. Yeah, so osteoclast. So these plasma cells that are in multiple myeloma, they produce a lot of cytokines which stimulate these osteoclasts. So these osteoclasts, if they're stimulated, then they start destroying bone. They start lysing bone or destroying, eating up bone. And of course, what happens is the bone is resolved. So you end up with bone that is very weak. That is how you end up with lytic lesions within bone. So there is net bone absorption or bone resorption. So the cause, etiology is a cause. Yeah, and remember etiology in some books you can write, you can spell it as Etiology. Yeah, but some books spell it as E, especially American books, they would want to use just E, they leave out the A. So etiology is a cause. So the cause of multiple myeloma yet is really unknown. So the incidence, if you are to look per annum, that is per year, in 100,000 people, that is worldwide, you may find that there are 4 people with multiple myeloma per year. So that is the incidence. So if you look at the male to female ratio, it's 2 to 1. So it's more common in male. So for every two men with multiple, 2 men, maybe you'll find one female with multiple myeloma, 2 to 1. So it's more common in male than female. Then the median age of diagnosis is around 60 to 70 years. So if you do average, most of the people diagnosed with multiple myeloma will be between 60 and 70 years. But of course, it can still occur even in younger people, but that is the median age. If you do averagely, the people who are affected will be between 60 and 70 years. And it's more common in Afro-Caribbeans, that is in Africa and those people in the Caribbean. And most of them will still be the blacks. So it's more common mainly in the blacks. And then you can see the next diagram basically showing the major sites that where you will find multiple myeloma. In the skull, in the ribs. It is less common in the upper limb. Yeah, but the skull, the ribs, can affect the pelvic bones. It can affect the lower limbs, although it's still rare also in the lower limbs. So more commonly will be the pelvis, the ribs, the vertebra, or the spine, and even in the skull. And then, of course, histologically, maybe because, as I said, for malignancies or cancer, tissue is the issue. So you must be able to do a tissue diagnosis. You must be able to, and in this case, malignancies involving the bone marrow or involving the blood, you want to take a blood sample. So mostly you want to do a bone marrow aspirate. In this case, you can see that is a bone marrow aspirate in multiple myeloma. So if you take an aspirate of the bone marrow and you know where you need to examine, because as we said last time, mostly in the bone marrow, the main places in an adult where you will find red bone marrow will be in those flat bones like the sternum, the skull, the pelvic bone, and even in the ribs. So if you are to do a bone marrow aspiration, mostly with most of the time because of accessibility, you tend to use the sternum. So if you take that aspirate from there and you stain it in a person with multiple myeloma, or where you suspect multiple myeloma and you want to make a diagnosis, so this what you will see on your right is you can see is a micrograph that is under the light microscope, which has been stained with Leishman type of stain. And then you can see on the left is the diagram of the same. So you can see there, you can see myeloid cells, myeloma cells, those are malignant cells. Yeah, and all that. So you can see, if you were to look at the microscope and you see a lot of myeloid cells, then you can say that is probably a multiple myeloma. And of course, that is one of the things that we do to diagnose multiple myeloma, where you suspect, you take a bone marrow, aspirate, and you stain it, you prepare it and stain it, and you look under the microscope.